The wrist broke from a fall that would not have broken it at 40. The back lost a centimeter of height between birthdays. The doctor recommended calcium, 500 milligrams every morning. You have been taking it for years. The density number on the scan barely moved. The question nobody answered: where did the rest go? You took the tablet every morning. You followed the recommendation. The density scan showed minimal improvement. 5 years of daily supplementation and the bones responded modestly. The calcium entered the bloodstream every morning. The bones did not absorb all of it. The remainder went somewhere. The somewhere is measurable: a coronary artery calcium scan. A CT image that directly visualizes calcium deposits in the coronary vessel walls would show you where the supplement went. The score correlates with supplement use across population studies. The higher the score, the more calcium has deposited in the arterial walls, the stiffer the vessels have become, and the harder the heart works against the rigid system the mineral created. Remainder went to the arteries. Calcium that circulates above the concentration the bones can absorb deposits where the blood flow is turbulent and the vessel wall is damaged, the arterial wall. The supplement prescribed to prevent bone fractures has been calcifying the arteries through the same hydroxyapatite crystallization chemistry the bones use. Same molecule, same crystal structure, wrong tissue. The delivery rate exceeded the bone's capacity, and the trafficking system that should have directed calcium to bone and away from arteries, a protein activated by vitamin K2, was sitting inactive because the cofactor was never prescribed alongside the calcium. The traffic cop analogy is precise. Matrix-Gla protein patrols the arterial wall continuously, produced by the vascular smooth muscle cells that line every artery. When activated by K2, the protein intercepts calcium ions at the vessel surface and prevents crystallization. When inactive, the protein sits in the wall, unable to bind the calcium flooding past it from the supplement spike. The patrol is present. The patrol cannot act. The raw material arrived. The traffic cop was asleep. 500 milligrams dissolved in the stomach, entered the bloodstream in a single spike, and the bones absorbed what their hourly incorporation rate allowed. The remainder deposited in the coronary arteries, the carotid arteries, the aorta, at every site where turbulent flow had damaged the endothelial surface. The supplement intended for the skeleton mineralized the vasculature. Why does the tablet deliver too much calcium too fast? Pharmacokinetics. The distinction between a supplement and a dietary source is the absorption curve. Both deliver the same calcium ion. The curve shape determines the destination, the shape of the serum concentration plotted against time after ingestion. Dietary calcium from food, yogurt, broccoli, sardines consumed across meals throughout the day, absorbed slowly across the small intestine through active transport and passive diffusion. Serum calcium rises gradually over 2 to 4 hours, peaks at a modest concentration. The kidneys and bones process incrementally and returns to baseline without exceeding the system's capacity at any point. The bone's osteoblasts incorporate calcium into the hydroxyapatite lattice at approximately 50 to 80 milligrams per hour. The dietary curve stays within this hourly rate for its entire duration. Every milligram absorbed has a destination. Supplemental calcium from a tablet. 500 to 1,000 milligrams of calcium carbonate or citrate dissolved in gastric acid. Serum calcium peaks within 30 to 60 minutes at concentrations 2 to 3 times higher than the dietary equivalent. The spike exceeds the bone's hourly incorporation rate within the first hour. The kidneys increase calcium excretion through reduced tubular reabsorption, clearing a portion into the urine, but renal clearance has its own rate limit. The kidneys can increase calcium excretion by approximately 50 to 100% above baseline, a significant increase but insufficient to clear a 500 milligram bolus that exceeded bone capacity within the first hour. The excess that remains above what the bones can incorporate and the kidneys can clear persists in the serum for 1 to 2 hours. During this window, every pass of blood through the coronary circulation delivers calcium at concentrations the endothelial surface does not normally encounter. The arterial branch points where turbulent flow has already damaged the endothelium-present calcium-accepting surfaces that the bolus concentration activates. Each daily spike is a delivery event to the arterial wall, circulating through the arterial system at a concentration the body was not designed to sustain from a single oral dose. The excess, the calcium above what the bones can incorporate and the kidneys can clear, circulates at supraphysiological concentration for 1 to 2 hours. Calcium pharmacokinetics from supplemental versus dietary sources follow this curve distinction through measurable serum time concentration profiles. Supplemental calcium produces peak serum concentrations significantly higher than dietary calcium from equivalent total doses. Heaney and colleagues measured these profiles in Osteoporosis International, same ion, same total daily dose, different curve. The practical implication is specific. 500 milligrams of calcium from 3 servings of dairy across the day produces a serum curve that stays within the bone's hourly absorption capacity for its entire duration. The same 500 milligrams from a single tablet produces a spike that exceeds bone capacity within the first hour and circulates the excess for 1 to 2 hours. Same total calcium, different curve, different destination for the excess. If you replace supplemental calcium with dietary calcium, spreading intake across 3 meals, you achieve the same total daily calcium at a curve the bones can absorb incrementally. The dietary approach eliminates the bolus spike that produces the excess. The coronary arteries never see the supraphysiological concentration the tablet creates. The molecule reaches the bone because the delivery rate matches the bone's absorption rate. The shift from supplement to dietary sources is the single most impactful pharmacokinetic intervention the evidence supports. Same molecule, same total dose, different curve, different destination for the fraction the bones cannot absorb in any given hour. The curve determines where the excess deposits because the excess exists only when the curve exceeds the bone's hourly capacity, and the curve exceeds that capacity only from the bolus the supplement delivers. The distinction is pharmacokinetic, not chemical. The calcium ion from a tablet and the calcium ion from yogurt are identical once they enter the bloodstream. What differs is the concentration time profile, and the concentration time profile determines whether the serum stays within the bone's absorption capacity or exceeds it. The bone does not care where the calcium came from. The bone cares how fast it arrived. I experience the pharmacokinetic distinction differently. The evening the curve shape replaced the phrase "good for the bones" in my understanding of my own morning supplement. The 500 milligrams I swallowed at 7 in the morning spiked my serum calcium by 8 o'clock. The bones absorbed 50 to 80 milligrams during that hour. The kidneys cleared a portion. The remainder circulated at a concentration the body does not normally reach from dietary intake, looking for a surface to deposit on. The same 500 milligrams consumed as yogurt at breakfast, cheese at lunch, and broccoli at dinner would have produced a curve that never exceeded the bone's hourly rate. Same total calcium. Different delivery. Different destination. The calcium spiked. The bones absorbed what they could. The excess circulated. The question is whether that circulating excess causes measurable harm, and a meta-analysis of 12,000 participants answered it. Does supplemental calcium increase cardiovascular risk? Calcium supplements increased myocardial infarction risk by approximately 30% across 11 randomized controlled trials and 12,000 participants. Bolland and colleagues published this meta-analysis in the British Medical Journal in 2010. The increase was measured in trials where calcium was taken alone, without vitamin D. Trials combining calcium with vitamin D showed a weaker, less consistent cardiovascular signal, a distinction that is important and not fully resolved. Updated analysis replicated the finding across additional datasets. Reed and colleagues confirmed this in Osteoporosis International in 2015. The association has been replicated across multiple meta-analyses. The Women's Health Initiative Calcium Vitamin D Trial, the largest randomized controlled trial of calcium supplementation, showed a trend toward increased cardiovascular events in the supplemented group, though the combined calcium vitamin D formulation partially attenuated the signal. The evidence is established. Supplemental calcium, particularly when taken without vitamin D and K2, increases cardiovascular risk through a mechanism the pharmacokinetics predicts and the vascular biology explains. Calibration. Cardiovascular disease is the leading cause of death in the 55-plus demographic. A 30% increase from a daily supplement is a significant absolute risk increase in a population already at elevated baseline cardiovascular risk. The supplement prescribed to prevent one cause of morbidity, fractures, measurably increased the leading cause of mortality, cardiovascular events. Additional calibration. Dietary calcium does not show the same association. High dietary calcium intake carries no increased cardiovascular risk across the same study populations. The molecule is identical. The curve is different. The risk follows the curve. The delivery method. The dietary calcium finding is the strongest evidence that the molecule itself is safe, and the delivery method is the variable. If calcium caused cardiovascular harm, dietary calcium would show the same association. Dietary calcium carries no increased cardiovascular risk. Harm traces specifically to the bolus delivery that supplements produce, supporting the pharmacokinetic explanation. The curve shape, not the ion chemistry, determines the cardiovascular outcome. Well, the 30% landed differently once the pharmacokinetic curve mapped onto the cardiovascular data. The supplement I had been taking every morning for 12 years produced a serum spike that exceeded bone capacity for 1 to 2 hours every day, 4,380 spikes, each one circulating excess calcium past arterial walls that had been accumulating endothelial damage for 6 decades. The 30% was the curve's consequence, measured across 12,000 people taking the same spike I was taking. Evidence established the risk. The question is where the circulating calcium deposits, and why the arterial wall accepts it. Why does the artery accept calcium? Dystrophic calcification. Calcium phosphate crystals forming at sites of existing tissue damage in the arterial wall. The arterial wall at branch points and curvatures experiences turbulent flow, the disturbed shear stress that damages the endothelial surface and triggers an inflammatory response in the vessel wall. The damaged endothelium undergoes a transformation. It begins expressing osteogenic markers, proteins normally found in bone-forming cells, and the vessel wall starts actively depositing calcium phosphate into its matrix. The deposition begins with crystal nucleation. Exposed collagen fibers at the damaged site provide a template surface where the calcium phosphate ion product exceeds the solubility threshold. The first crystal seed forms at the template through epitaxial growth. Calcium and phosphate ions from the supersaturated bolus concentration, adding to the seed one ion layer at a time. The physics is identical to scale formation in water pipes, mineral deposits at surface irregularities from supersaturated solution, same crystallization, different pipe. Once the seed forms, growth accelerates because the crystal surface itself becomes a template for further deposition. The growing crystal incorporates ions from each subsequent supplement, spike through the same hydroxyapatite crystallization chemistry. The teeth discussion for enamel. Crystallization chemistry is identical. Calcium ions and phosphate ions combining into the hydroxyapatite crystal, the same crystal structure that forms tooth enamel and bone matrix. Same molecule. Same crystal lattice. Different tissue. The artery is mineralizing through bone chemistry at sites where endothelial damage exposed the matrix to circulating calcium. The calcification is biologically active. The damaged vascular smooth muscle cells have undergone phenotypic transformation, switching from their normal contractile function to an osteoblast-like mineralizing function. The cell that should be contracting to regulate blood flow is instead depositing calcium phosphate crystals into the vessel wall, the way an osteoblast deposits crystals into bone matrix. The transformation is triggered by the inflammatory environment the endothelial damage creates, and the circulating calcium provides the substrate the transformed cells use to build the crystal. Coronary arteries at 3 to 4 millimeters in diameter experience high flow velocity and frequent turbulence at branch points. The coronary artery calcium score on cardiac CT directly measures this deposition. Studies show correlation between supplement use and elevated coronary calcium scores. Calcium supplement use is associated with higher coronary artery calcium burden on imaging. Anderson and colleagues described this correlation in the Journal of the American College of Cardiology. The association is dose-dependent. Longer duration of supplement use and higher daily doses correlate with higher coronary calcium scores, supporting the cumulative deposition model the pharmacokinetics predicts. Now the calcium deposited in the artery through the same chemistry the bone uses, the delivery rate overwhelmed the bone's capacity, but the body has a system specifically designed to prevent arterial calcification, a protein that binds calcium in the vessel wall and blocks crystallization. The protein exists, it requires activation. The activator was never prescribed. What keeps calcium out of the arteries? Matrix-Gla protein. The most potent endogenous inhibitor of vascular calcification. Matrix-Gla protein binds calcium ions in the arterial wall and prevents their crystallization into hydroxyapatite. The protein is the traffic cop. It patrols the arterial wall, binds the calcium that arrives, and prevents the crystallization that would convert the calcium from a circulating ion into a structural deposit. The traffic cop keeps the calcium moving and prevents it from settling. When matrix-Gla protein is fully carboxylated and active, arterial calcification is measurably suppressed even in the presence of elevated circulating calcium. The protein physically binds the calcium ions at the vessel's surface and prevents the crystallization nucleation event that would begin the hydroxyapatite formation. Each active matrix-Gla protein molecule binds multiple calcium ions through its carboxylated glutamic acid residues, and the protein is produced constitutively by vascular smooth muscle cells, specifically to maintain this defense. The system works. It requires K2 to function. Without K2, the protein is manufactured, secreted into the vessel wall, and sits there unable to perform its function, a defense system that exists but is operationally offline. Measuring uncarboxylated matrix-Gla protein in the blood reveals how much of the defense is inactive. Higher levels mean more protein sitting unused, and higher levels correlate with faster arterial calcification progression. Matrix-Gla protein requires activation through carboxylation, adding carboxyl groups to glutamic acid residues on the protein's surface. The carboxylation enzyme, gamma-glutamyl carboxylase, requires vitamin K2 as its obligate cofactor. K2 serves as the electron donor for the enzyme, providing the reducing equivalents the carboxylase needs to add a carboxyl group to each of 5 specific glutamic acid residues on the matrix-Gla protein surface. Each carboxylated glutamic acid residue carries an additional negative charge that enables it to chelate calcium ions through electrostatic attraction. 5 residues carboxylated means 5 calcium binding sites activated. Without K2, the enzyme cannot perform the carboxylation. The residues remain uncharged, and the protein cannot bind the calcium it was designed to intercept. Without K2, matrix-Gla protein remains uncarboxylated, inactive, unable to bind calcium. The arterial wall loses its primary calcification defense. You taking calcium supplements without K2, maximum deposition substrate, with minimum deposition protection. The calcium bolus delivers the raw material at supraphysiological concentration. The inactive matrix-Gla protein cannot prevent the crystallization. The arterial wall, already damaged at branch points, deposits the available calcium into its matrix through the osteogenic transformation the damage triggered. The raw material arrived. The traffic cop was asleep. The calcium went wherever the damaged tissue accepted it. Vitamin K2 activation of matrix-Gla protein as the primary vascular calcification defense is established biochemistry. K2-dependent carboxylation of matrix-Gla protein is required for its calcium binding and anti-calcification function. Schergers and colleagues established this in blood. The uncarboxylated matrix-Gla protein level is a measurable blood test that indicates whether your arterial calcification defense is active or inactive. A high uncarboxylated level means the protein exists but is not functioning because the K2 cofactor is insufficient. The test is available but rarely ordered in routine screening, meaning the arterial defense status of you taking daily calcium is typically unknown to both you and the prescribing physician. K2 dietary sources: natto at approximately 1,000 micrograms per 100 grams, hard cheeses like Gouda and Brie at 50 to 75 micrograms, egg yolks and liver. The Western diet is typically low in K2. Natto, the richest dietary source, is consumed almost exclusively in Japan. Hard cheeses provide meaningful amounts but require daily consumption of 50 to 100 grams. Egg yolks provide small amounts requiring multiple eggs daily. The gap between dietary K2 intake and the amount required for full matrix-Gla protein carboxylation is large enough that supplementation of K2, specifically the MK7 form at 100 to 200 micrograms daily, has been proposed as a companion to calcium supplementation for precisely this reason, activating the traffic cop before delivering the cargo. The demographic most likely to take calcium supplements, adults over 55 concerned about bone density, is the demographic least likely to consume adequate K2 from dietary sources. The substrate was prescribed, the activator was not. The prescribing physician recommended calcium for bone density. The prescription did not include K2. The deficiency in K2 was not measured. The uncarboxylated matrix-Gla protein level, the blood test that would reveal whether the arterial defense system was active or inactive, was not ordered. The calcium arrived without the cofactor that determines whether it reaches the bone or deposits in the artery, and the cofactor was absent because the prescribing framework did not include it. The gap is institutional. Calcium supplementation entered clinical practice before the K2 trafficking mechanism was fully characterized. The recommendation to supplement calcium for bone density was established in the 1980s and 90s. The role of K2 in activating matrix-Gla protein and preventing vascular calcification was characterized in the 2000s. The clinical practice preceded the science that would have modified it, and the prescribing framework has been slow to integrate the newer evidence. The result is a generation of adults who have been taking calcium supplements for bone density for 15 to 20 years without the K2 cofactor that would have activated the arterial defense and the bone incorporation machinery simultaneously. The traffic cop was never activated, the calcium deposited where it should have been blocked, but the calcium was also failing to reach the bones it was prescribed for, because calcium is one of 4 inputs bone remodeling requires, and 3 of the 4 were missing. Why did the calcium fail to reach the bones? Bone remodeling requires 4 inputs. Calcium is one. The supplement addressed 1 variable, while 3 remained absent. Vitamin D enables intestinal calcium absorption. Without adequate vitamin D, dietary and supplemental calcium passes through the intestinal tract with reduced absorption efficiency. Vitamin D activates the transcellular calcium transport pathway in the small intestine, the active transport mechanism that pulls calcium ions across the intestinal wall into the bloodstream. With adequate vitamin D, absorption efficiency runs at 30 to 40%. Without it, efficiency drops to 10 to 15%, and the calcium that is absorbed enters the bloodstream without the bone incorporation machinery being fully active. Vitamin D deficiency is common in the 55-plus demographic, particularly in northern latitudes where winter sunlight is insufficient to drive cutaneous vitamin D synthesis. If you take calcium for bone density without adequate vitamin D, you absorb less calcium from the tablet and incorporate even less of what is absorbed into the bone matrix, because D also supports osteoblast function at the bone surface. The calcium that reaches the bloodstream but cannot enter the bone matrix because the incorporation machinery is incomplete circulates until it finds another destination. Vitamin K2 activates osteocalcin, the bone matrix protein that incorporates calcium into the hydroxyapatite lattice. The same K2 that activates arterial matrix-Gla protein activates bone osteocalcin through the same carboxylation chemistry. Without K2, osteocalcin remains uncarboxylated, unable to bind calcium into the bone matrix. The bone cannot incorporate the calcium the supplement delivers because the protein that performs the incorporation is inactive. Mechanical loading provides the deposition signal. Bone is a piezoelectric material. Deformation under load generates electrical potential across the crystal surface, and osteoblasts respond to the electrical signal by depositing new matrix at load-bearing sites. Without mechanical loading, without weight-bearing exercise that deforms the bone under physiological stress, the osteoblasts receive no deposition signal regardless of how much calcium circulates. The calcium passes the bone the way a delivery truck passes a warehouse with no loading dock. The material is there. The unloading mechanism is absent. Walking produces the mechanical loading the bones require. Each heel strike transmits force through the skeletal chain, deforming the bone matrix by micrometers, generating the piezoelectric signal that recruits osteoblast activity to the loaded sites. If you take calcium supplements but do not walk regularly, you provide the building material while omitting the construction signal. The calcium circulates past bones that have no reason to incorporate it because the signal that would trigger incorporation never arrived. Calcium without D, K2, and loading was one input into a system that requires 4. The bones received a fraction because 3 of the 4 incorporation mechanisms were inactive or absent. The arteries received what the bones could not incorporate because the defense system that should have blocked the arterial deposition was inactive. For the same reason, the bone incorporation was incomplete. The K2 was missing from both. Now the calcium deposited in the arterial wall produces a consequence the bladder discussion described through different tissue, reduced compliance. The calcified arterial wall cannot expand with each pulse the way the elastic wall can. Pulse wave velocity increases through the rigid segment. In a compliant artery, the pulse wave travels at 4 to 5 meters per second and reflects from branch points back toward the heart, arriving during diastole when it augments coronary perfusion. In a calcified, stiffened artery, the wave travels at 8 to 12 meters per second, and the reflected wave arrives during systole, adding its pressure to the systolic peak the heart is already generating. The augmentation increases the workload the heart must sustain with every beat. Systolic blood pressure rises because the vessel cannot absorb the pulse energy through elastic expansion. The isolated systolic hypertension common in the 60-plus population, systolic pressure rising while diastolic stays stable or drops, is the hemodynamic signature of arterial stiffening. The gap between systolic and diastolic widens as the arteries lose compliance. The pulse pressure increases. The heart generates more force per beat to push blood through a system that cannot expand to receive it. The pulse wave velocity number carried different weight the week. The calcium burden connected the supplement to the stiffening the arterial test was measuring. Heart works harder against a system that's stiffened from the supplement you took to protect a different structure entirely. Pulse wave velocity, measurable through non-invasive arterial testing, quantifies the stiffening. A higher velocity means a stiffer vessel wall, and studies correlating pulse wave velocity with coronary artery calcium scores show a direct relationship between the calcium burden in the wall and the loss of elastic function the heart must compensate for. The stiffening is progressive. Each year of supplementation at bolus doses adds to the calcium burden, and each increment of burden reduces the compliance the pulse must travel through. Whether your calcium supplement should be continued, modified, replaced with dietary sources, or paired with vitamin D and K2 is a clinical conversation with your physician based on your bone density, your cardiovascular risk profile, your dietary calcium intake, and your coronary artery calcium score if measured. The physics teaches where supplemental calcium goes when the bones cannot absorb it. The physician determines what your specific risk-benefit profile requires. Same molecule. Same crystal. Wrong tissue. The delivery rate determined the destination. 4 inputs build bone. 1 was prescribed. The 3 that determine whether the calcium reaches bone or artery were absent. The supplement was never wrong as a molecule. The supplement was incomplete as a protocol.